Good morning, and thank you, Emily, for the introduction. As you all understand, the roadmap to making genomics routine spans that boundary between the innovative and complex medicine and science that underpins genomic care and the operational health service programs that can, when they're optimised, provide the opportunity to embed genomic care into routine health practice. So the way we're going to spend our 30 minutes is hearing three short presentations about these fantastic programs. That they are quite different. So we have paediatrics, nephrology and oncology. So we're approaching this from three very different discipline backgrounds. And our speakers will give an overview of their program and the challenges and unique learnings that they encountered in their actual program. And then after we've heard from the three presenters, we'll bring that together in the last remaining few minutes to discuss the collective learnings and shared messages, because that's what will hopefully take us forward into the rest of the day. So to start us off, our first presenter is Dr Emma Weiss from Melbourne Genomics, who has run a program in paediatric genomic care.
Okay. Hi everyone, thanks very much for having me. I wanted to talk a little bit about the paediatrics genomics program, and so I wanted to let you know at the point that I came into the paediatrics project. Thank you very much for making that bigger so I can actually see it. Genomic testing was recently Medicare funded for eligible children, and the problem we were looking at is why aren't paediatricians using genomic testing? What are some of the barriers and how might we overcome that? So I'll talk you through a little bit of how we faced that. The first thing that we did was to try and hear from paediatricians what was the thinking towards genomic testing. So what we learned was that it was perceived to be beyond the scope of practice and too time-consuming for general paediatricians to adopt into their practice. There was no known pathway for support. Paediatricians didn't know where to turn, and the systems weren't set up to support paediatrician ordering of genomic testing and mainstreaming of genomics into paediatrics. And so that was what we were facing. And what we did to combat that and how we went into mainstreaming genomics into paediatrics was, the most important thing was co-design, making sure that the people who were going to be using these services and involved with them were working from the ground up to build them. And so what we ended up with was a suite of profession-specific support services for paediatricians. And so primarily that was comprised of an online step-by-step guide, which takes a paediatrician from beginning to end through the process of genomic testing, a genetic expert contact service, so having somebody available business hours Monday to Friday to be able to talk immediately through any issues, service available after hours by email as well. And then with those resources, having a targeted advertising program to actually be able to get the resources to the people who could use them in a timely way and in a way that was known to work seamlessly in with their workload. And the way that we did that was by using a genomics champion. So a genomics champion is somebody who walks in two worlds, in this case in paediatrics and in genomics, and build bridges between the two previously siloed areas to facilitate an understanding and to support working together to meet the outcome of bringing genomics equitably to children across Victoria. So one of the learnings from our program was that we had these fantastic, amazing, wonderful resources, and if only we could get paediatricians to use them at the right time in the right way, that would be fantastic. But what we found was that paediatricians were still requiring an experiential learning clinic or a opportunity to be led through using the resources in a real way so that then they could integrate using them into their practice. So what we developed was an experiential learning clinic called the Paediatric Exome Clinic. And so that has 3 main functions. So service provision, education, and building connections. And you can see there, basically what happens is that paediatricians refer a patient to the clinic. They then come along with their patients to the clinic. We go through the process of genomic testing, teaching the paediatrician how to do it as we perform that service for that family, and then provide the paediatrician with all the tools that they need to be able to do that independently for their next set of patients, and to then share all of those resources with their colleagues after they've benefited from coming to the clinic. It also builds connections between general paediatrics and the genetic service, so that the two can work together for the benefit of all the families. So the key takeaways that I've got from building this service was the need for co-design, making sure that the people who are going to be using the service are involved in building it. The role of a genomics champion to make sure that the service that's built meets the needs of all parties and is integrated into the health service in a way that's actually going to practically work. Ease of access of the resources, and making sure that the resources support beginner to expert learning in a range of ways to suit lots of learning styles, that there will always be a need for experiential learning as well, and to make sure that that's taken into account, and to build lasting connections between all players. And so I'll hand over to Kush.
Thanks, Emma. Thanks, Emma. So I'll be talking about our mainstreaming project in nephrology. So this began after we and other Australian researchers, and you've heard earlier today, that we've demonstrated that genomic testing for kidney disease has a high diagnostic yield, is clinically useful, and has health economic benefits. So some of the research contributed to evidence to support the creation of Medicare item numbers for genetic testing for patients with kidney disease. With this coming in, we predicted an increasing demand on the genetic services, which are resource intensive and may not be sustainable with the growing demand for testing. So recognising this bottleneck and the rising wait times for genetic services, we aim to empower nephrologists to use the Medicare item numbers themselves in order to increase patient access to timely genomic testing through what we call mainstreaming. And we've referred to that today multiple times, but I guess in the nephrology context, mainstreaming really means that nephrologists can order tests, interpret results, and discuss findings with their patients as part of their routine care in their kidney clinic, rather than always referring to genetic specialists. So in terms of our new model of care, we rolled out a new model across 3 tertiary adult sites and 1 paediatric site in Victoria. So this was a sort of hub and spoke model, as you can see, where the hub were the tertiary genetic centres with clinical genetic units already in place, and they were based at Royal Melbourne, the Austin, Monash Health and the Royal Children's. So these hubs supported nephrologists within the hubs themselves, as well as other peripheral nephrology units to order genomic tests. And our model incorporated 3 key interventions to enable mainstreaming, all of which were highlighted as key enablers in some of our previous work using national survey and interview data from nephrologists. So we've talked about genomic champions, and we used a bit of a multi-pronged approach. So we had champions that were nephrologists, but also renal nurses, as well as genetic counsellors who were there within the units to support mainstreaming. We also, a key intervention was a statewide mainstreaming multidisciplinary team meeting, and this was held virtually every fortnight for nephrologists from Victoria to discuss any cases that they had. And then we had a suite of decision support tools. And I've shown some of these here. So the decision support tools focused on educating nephrologists on who should be tested, but as well it focused on improving efficiencies in the clinic. So we looked at the low-hanging fruit, highlighting who should be tested in a mainstream setting, and then differentiating which patients were more complex and should be referred to genetic services. And then to streamline testing processes, we made clinician resources to help with selecting patients, ordering the right tests, and then results interpretation. We also made patient-facing resources, and we focused on the most common genetic kidney conditions that nephrologists face in their clinics every day. So looking at some of our data around the impact of this intervention across the project, what we did was compare testing numbers and compared things during 3 time points. So we looked at time point 1, which was a year prior to the Medicare item number for general monogenic kidney disease being introduced, a year after the MBS item number, and then a year following the intervention, being time point 3. So as you can see, the pie charts on the left show the number of tests ordered in a mainstream setting, and they increased from 6% in time point 1 to 42% in time point 2, and again to 70% following the mainstream model of care. The figure on the right shows the number of tests ordered at each of the sites. And as you can see, there's differences in testing patterns from start to finish, but the number of tests ordered have steadily increased across the 3 time points at each site. And I haven't shown the diagnostic yield, but our diagnostic rates have also remained similar following the new model of care, which is reassuring that the appropriate patients are being selected for testing. So what are some of the key insights from our project? I think one of them is that champions and leadership drive change. So we actually surveyed about 70 or so nephrologists in Victoria before and after the intervention. And we found that the local nephrologist champion was the most valued resource, followed by statewide MDTs and then decision support tools. And I've talked about those 3 resources, but there was a multitude of other resources in the project as well. We found that there was also strong leadership from department heads, and stakeholder engagement were really key for uptake of testing. Secondly, initial investment pays off, and so upskilling these champions within the nephrology units created lasting impact. So many champions following the project completion continue their role informally, and the resources that we've developed during the project remain widely used and valued across sites, and they'll be implemented nationally moving forward. And thirdly, flexibility and collaboration led to success. So there was really no one-size-fits-all approach in our project, and the resources and strategies really needed to be tailored to the expertise levels and individual site needs. Practical, non-technical insights in our mainstreaming MDTs made genomics more accessible, and that sort of evolved over the course of the project. And the project facilitated stronger, lasting links between nephrologists and genetic specialists, which really led to better coordination of genomic care overall, and will continue. Thanks, and I'll leave it to Kortnye.
Good morning, everybody. My name's Kortnye. I'm a medical oncologist. I work at both a quaternary cancer centre, so somewhere that's very, very used to using genomics, and I've also worked regionally and in a smaller, more sort of standard public health system. So I have experience across a lot of different health systems. And that's important because, just like the other 2 have indicated, there's a lot of variability in the understanding of genomics and how comfortable people are in using that information for their patients. And a lot of what we're trying to do is try and smooth that across so that all patients have equitable access, regardless of which hospital they attend or where they happen to be located. So I think importantly, I think Paul touched on it earlier, is the way that we use genomic sequencing within cancer is a little bit different in the way that it's used in other medical specialties. So there's really a number of things that we can do. We can use the testing to help us with diagnosis, and we saw that in the case that was discussed earlier today, that sometimes using that genetic information can provide you with more information than looking at histopathology can, and it can help us make more accurate diagnoses. It can often help determine the tumour of origin. We can look at the original site of the cancer. We can look at prognostication and prediction in terms of what medication may work for a patient, and prognostication in terms of life expectancy or changing the type of diagnoses. The thing we talk about a lot is treatment options, so looking at things that may assist a patient in their cancer responding more effectively, targeted therapies, which really, as Paul said, have changed the face of the way that we treat cancer. And then germline variants, so things in somebody's pre-existing DNA that may influence their susceptibility to cancer. And so what this looks like is we actually use a combination of 3 different types of testing for our patients. We do use germline testing, and Paul talked about that earlier, in that we can use testing to look at cancer susceptibility genes. But really, oncologists don't get involved in that particularly unless it's a special interest. The time that we get involved in germline testing is when we're looking at somebody who has a pre-existing cancer diagnosis. So in those patients, there is a small subset in which that germline mutation may impact what treatment they are then given. And we use that type of testing in a similar mainstream, which has only really rolled out over the last 5 years, allowing oncologists to provide the education and results for that for their patient group. We also use somatic testing, which is where we test the tumour itself. So here we're looking at the DNA of the cancer and not the DNA of an individual, although you do find that out as part of the testing as well. So this brings with it its own set of issues. So tumour tissue can either be gained by surgical samples or by biopsies, which are of various sizes and qualities. We run into problems because the best sample is a fresh tissue sample from surgery, and that's really hard to get. Frozen is the next step down, but only paediatrics have the ability to utilise that in general. And most of our samples come from FFPE, which for the scientists in the room will know that comes with its own issues in terms of testing. But that composes about 95%. We then add logistical issues, which is really what we're here to talk about. The tissue could be anywhere. It can be in private laboratories, it can be interstate, it can be very small, it can be poorly stored. So we then run into problems with managing that. So the quality and access becomes challenging. We can also use more recently circulating tumour DNA, which is where we look at the circulating amounts of DNA from the tumour itself that has been that's present in the normal blood. It tends to be about sort of less than 1%, so it's looking at very small amounts. Both of these things we can run into trouble with failure because the testing may not work, and we can also find incidental germline findings in both of these types of testing. And so because of that, our oncologists can sometimes struggle with how to correctly implement genomics in their specialty, how to do that in a fairly time-rushed situation and within the normal consultation with a patient who is fairly overwhelmed about just being told that they have cancer. These tests aren't standard of care, both the testing and the use of testing. So the results that come back to the oncologist who's sitting there may indicate that there's a mutation or a variant detected in their DNA, but they then need to work out what in the world they're going to do with that. Is there a treatment available? Is there a medication that they can access? How can they access that? We know that support's required for oncologists to upskill. We know that there are challenges communicating the results with patients. Currently, the expertise is relatively centralised in terms of the hospitals that provide it. And we know that we need support from our familial cancer centres to buy in, because really once we get to that idea of germline variants, we run into trouble. And so just to briefly go over our models of care, we launched a program across Victoria, both in public, private and regional centres, which looked at different models of care. So we looked at a non-supported model to be our baseline, looking at telehealth, and then looking at centralised models. So that ran over a period of about 2 years, looking at circulating tumour DNA. And really nicely, I don't actually have to summarise most of it because Kush summarised it pretty well, because our results were very similar. Patients like getting information from their own oncologist. They would much prefer that than having telehealth, although they do feel there's something nice about having a separate person explain the same set of results to them. Just not surprising. We know that the number one facilitator is having a passionate local support person, whether that be a nurse, a registrar or an oncologist, so somebody on site who is really pushing and advertising and advocating. And we know that the third thing that's important is having someone to turn when you get information that you don't know what to do with. And so the weekly molecular tumour boards held via video link were really the linchpin in what helped our oncologists feel confident in the way that they treated things, having somebody to turn to. And so it's nice to see that echoed in other people as well.
Great, thank you. Thank you all. And really, thank you for giving those presentations so succinctly and so clearly in 6 minutes. And I think we all know the 6-minute presentation is harder to give than the 1 hour long keynote, because you just don't have much time. So thank you very much. I have a few questions for you, and I'd probably like to start with a question to Kush, because you were bringing together a number of organisations there, and may I say, when those Medicare item numbers commenced for clinicians and outside of genetic clinics, some of us did start to worry about the number of tests that might be ordered and all sorts of impacts that might be experienced across healthcare. But given the work you were doing, what was the difference? What differences did you maybe see in how the program rolled out versus how you might have expected it to right back at the start?
Thanks, Kerryn. Great question. I think we were fortunate in nephrology to have done some background work and ask clinicians what they wanted and what were the barriers of using these item numbers before. So that helped us, kind of have that multi-pronged approach. But everything kind of needed to be adapted during our model. I guess we invested a lot in a genetic counsellor to be within the unit, whereas we found during the project that nephrologists were just more comfortable asking a nephrologist for guidance and asking a colleague that was local to their team for guidance. So that was one of the interesting findings that we had. And I guess all of our interventions kind of needed to adapt to, as you said, like we had multiple sites. Everyone had their own nuances. So the paediatricians, for example, they had less than 10 paediatricians in the department that needed to upskill. They were a lot more confident at the beginning using genomics, thanks to Kathy Quinlan. So they didn't need their own champion. They were all champions within their unit. So we didn't fund an actual nephrologist champion there. Whereas it worked really well for the other sites where there was 30 or so nephrologists at some, having that one local person to go to for guidance. So I think being able to adapt and ask all the stakeholders, what's important, what will work, and then change that when it doesn't work, helped in our case.
Emma or Kortnye, did you want to comment on that as well?
Sure, I'm happy to comment. So we saw something really similar in the paediatrics project, whereby we thought having all these fantastic resources and advertising them widely and in a really targeted way would work well. And it did to a certain extent, but it wasn't until we had that opportunity for one-on-one experiential learning that things really took off. So the ability to adapt and progress things as we went along was really important.
Great, thank you. Kortnye, I have a question for you, and I'm partly going to be wearing my medical workforce hat and partly my pathology hat. But what capabilities do you think across healthcare, and because you've worked in three very different environments, what capabilities do you think we need to develop? Because even in the various areas of expertise that we need, there are long lead times. It involves changes in organisational arrangements, access to technology, What do you see as some of the big priority areas to develop?
Good question. I think the first thing is a bit of a mind shift in terms of just acknowledging that this needs to become standard of care. We need to accept that genomics is real, and that it's something that is essential in the way that we treat patients. It can both cost money and save money. I think education is really important. Pathology, in the same way as oncology, has had a very rapid increase in the amount of information they need, and it's not in our training programs. Genomics is not a standard part of that. It's starting to become more so in pathology. So I think there does need to be subspecialty awareness, and I think also there probably is going to be some centralisation of skills, but it's how we then support our smaller health services to be able to have access to that. And I think, particularly in Victoria, that's a very topical issue of how we support the smaller groups and how we structure that. So I think that will be interesting to see going forward, because I don't think we can do this as each individual health service having their own genomics program that works independently of each other.
I totally agree. And I think, just for anyone who doesn't know, a lot of the laboratories that might be able to do some of the somatic testing don't necessarily have the capabilities around germline. So that's, another sort of aspect in there as well. Emma, paediatrics is the testing, the genomic testing in paediatrics. Some of the tests are at the more expensive end compared to, say, the cancer testing. How are experts in your field liaising with health service leaders to discuss the financial impacts and future opportunities in the paediatric genomic space?
Sure, absolutely. So one of the reasons we talk about it being a little bit more expensive perhaps than cancer genomics is because in order to get the best results, we're talking about testing 3 people together, the child with both of their parents. But when you're considering what you're balancing against genomic testing for these children, to put it into context, we're talking about looking for a single gene change in a child that is causing either intellectual disability or facial and body changes, so congenital anomalies, which has lifelong impacts for the child and their family in a number of different domains. So what we're doing is we're really balancing a genomic test which per instance is actually not particularly expensive when you're comparing it to the cost of, let's say, an MRI, which in a child needs a general anaesthetic. You've come out even every time. And so when you're doing these tests at an early age, as many other speakers have talked about before, you're balancing a one-off cost with the benefits that are lifelong. So less need for investigation, much more targeted investigation, targeted treatments. And so there's benefits to the health service there.
Great. Thank you all. I'll hand back to Emily.